thank you for joining us on this very cool and sunny fall day. We're glad that you're here. Can I see a show of hands of anybody who in their lifetime has had vision rehabilitation services? All right, great, wonderful. So for those of you, this is going to kind of be, you could probably be up here doing the presentation because you kind of know what's involved in a low vision rehabilitation exam. And for those of you who are not familiar with it, I'm going to go through the process of kind of just the sequence of events that go through doing a low vision evaluation. What a low vision evaluation is, it's not a routine eye exam. It's not a dilated eye exam. In fact, to get to us, you have to make your appointment, the first thing you have to have, our administrative assistant, Jackie, will ask you, when was your last dilated eye exam? We have to have that. That's step number one. We need to have that dilated eye exam done because we're not going to dilate your eyes. We're not going to put any drops in your eyes. We're not going to do any visual fields. Everything at Vision Forward is about function. So when you schedule an appointment at Vision Forward, it's going to be for 2 hours. Your first assessment is going to be for 2 hours. The first hour is with me. The second hour is with the occupational therapist. And in a nutshell, what I do as part of the optometric low vision assessment is, one, make sure you have the absolute best eyeglass prescription to be combined with other types of magnification. Two, I'm going to see how you respond to magnification. Does it make it better? Does it make it worse? Does it have any impact at all? If it makes it better, and I'll be honest, 9 times out of 10, it's going to make it better, then we're going to determine how much magnification is it going to take to help you see the things that you want to see. And we spend a lot of time figuring out what it is you want to see. We'll spend 20 minutes in conversation setting up goals, okay? I tell my patients, let's put together a wish list, if you will, of things that you would like to see better. And let's put it in order of priorities, okay? So we're going to kind of focus our attention on the things that are most important to you. The low vision evaluation is a great opportunity for you to ask questions about your medical diagnosis. Oftentimes, patients will come in and say, well, the doctor came in and said, I have macular degeneration, I'll never go blind. There's nothing more I can do for you. What? Where do I go from here? It's a frightening thing to hear that. If you have dry macular degeneration, they'll put you on the eye vitamins. If you have wet macular degeneration, as you know, you're seeing them every 6 weeks for the injections. But now, where do I go? What do I do? I need to be able to read my mail. I need to be able to pay my bills. I need to be able to get from point A to point B, get my kids back and forth to their practices and their meetings. And that's what we at Vision Forward try to help you do and figure out how to do all of those kind of things. So putting together that wish list is very important. I will do a trial frame refraction. So patients will often say, I just had my glasses checked. Doctor told me I don't need new glasses. That's not going to help. That may be true for what I would call your general purpose eyeglasses, that the glasses you walked in with are in fact the best possible prescription to focus the light onto your retina. But it's not the best prescription to be combined with other types of magnification. So part of the trial frame refraction is going to be getting you out from behind that phoropter, that's that big mask that you sit behind, and putting some glasses on your face and letting you use it in real space, okay? And teaching you how to use the potential eyeglass magnification properly. Low vision evaluation is also the opportunity, as I was mentioning earlier, to ask questions about the diagnosis. So again, I have macular degeneration. Am I going to go blind? Am I going to be totally in the dark? What's the prognosis of retinitis pigmentosa? I have diabetes with macular edema. What does that mean? It's an opportunity to get more information about your diagnosis. And you'll hear me referencing macular degeneration a lot, so I apologize if that's not your diagnosis, but that's the majority of patients I see at Vision Forward are patients with macular degeneration, which is a central vision loss. If you're looking at a paragraph in the newspaper, you can see the first word, you can see the last word, but the one right in the center, that's the one that's hard to see. And with macular degeneration, an absolute grid is often given to the patient by their eye doctor. And I'll ask the patient, are you using that grid? And they'll say, well, I have it at home. It's on my refrigerator. Yeah, I think I looked at it last month. And I ask the question, well, do you know why they gave you that grid? And they say, yeah, to check to see if it changes. Well, what does it mean if it changes? And that they don't know. So going back to what I was saying, this is your opportunity to find out why. The Amsler grid is an important test to do on a very regular basis, because if you have dry macular degeneration, that can change to the wet type. And the Amsler grid is the way to watch for that change and catch it early. The treatment for dry macular degeneration is the eye vitamins. The treatment for wet macular degeneration is the injections. The injections are most effective if we start doing them early. So it's your opportunity to get more information about your diagnosis, more information about your prognosis, and is there anything I can do or do differently to help me maintain the vision that I have? Setting out those goals. I often tell patients, I want you to think of yesterday. Okay, so today is Friday, so think of yesterday, from the day you got up until the time you went to bed. Give me some examples of things that you had a hard time seeing. Okay, and let's put those things together. Is it watching TV? Is it, like I said, balancing your checkbook? Is it, I just want to read my mail? Is it leisure reading? I am a book of the month club kind of a person. I have patients say, my goodness, I used to go through 3 books a week. I was at the library all the time. The magnifier that we might use for somebody who is a leisure reader will be different from somebody who says, I just want to be able to read the labels on my medication bottle. It's all reading, but it's different types of reading. And the magnifier that might be the best for each one of those tasks will be different. So we're kind of trying to help you put together your low vision toolbox, if you will. I know that at home you have a hammer and a saw and a screwdriver, and you wouldn't use a hammer to cut a board. Magnifiers work the same way. The magnifier that's going to help you see detail on the television will be different from the magnifier that you will use to read your mail. So that's why we want to put together that list of goals. I do not want to spend a lot of time looking for a magnifier to help you read the stock market quotes, if really all you want to do is read the large print Reader's Digest. So that's why we put together that list of goals. What you see up here now on the screen are some pictures of the different eye charts. When you go to your eye doctor, oftentimes they turn all the lights off and they have you look at the eye chart across the room and ask you to read it. Well, we don't do that at Vision Forward. How often are you reading things in the dark? Right? That's not real. I intentionally leave the lights on in the exam room because I want to know how much that glare from those overhead lights is going to affect your vision. We're real world. We're all about function, not the artificial environment. Okay. We also, our reading cards will be a little bit different from the ones that you have when you're in to see your dilated eye exam. We're going to look at just the 5 letters in a row, but we're also going to look at paragraphs. Reading 5 letters in a row, random letters in a row, is a whole lot different than having to read a paragraph. Because when it comes time to read a paragraph, now you've got long words and short words, and you got to be able to go from the end of one sentence to the beginning of the next sentence and not lose your place. So it's important that we take it out of the clinic setting and put it into the real world setting. How are you functioning with these things? Our eye chart, it's a low vision chart. It's designed specifically for people with less than normal vision. When you go in to see your eye doctor, everybody knows the big E, okay? That letter is a 20/200 letter. That's the standard eye chart. When we do a low vision assessment, our standard eye chart starts with 21,000, okay? Because I know your visions may not be 2,200, but we want to be able to get an idea of what you can see. So our charts are a little bit different than what you might get when you have your dilated eye exam. The phoropter, that's that mask that I was talking about. That's that in your dilated eye exam, they put you behind that mask. They ask you which is better, 1 or 2, to find out what your eyeglass prescription is. I'm going to put you behind the mask for a very brief period, and then I'm going to take that away. The trial frame kit. In there, you see hundreds of different lenses, and you see a pair of wonky-looking glasses. They're heavy, they're loose. There's not anything nice I can say about them except They let us try it. They let us see if changing the power of your glasses will make a difference. So we're going to put that trial frame on and let you look in the distance with it, let you look up close. The other nice thing about the trial frame is that when you're behind the phoropter, you don't get a lot of patients with central vision loss from diabetic retinopathy or macular degeneration will find that, they turn their head just a little bit, their vision's a little bit better. Well, you can't do that when you're behind the mask. Again, everything with vision rehabilitation is about function, what's going to make it best. We're going to put all the ducks in a row. I want to do every little thing we can to get the most out of your vision. And when we add them all up together, that's how we get the greatest impact. So part of the low vision assessment, as I said, I'm going to put magnifiers on. The first magnifier I show absolutely everybody is a telescope. It's like what a hunter would use on a rifle. And I will put it over your better seeing eye. Most likely not going to put it over both eyes. And if you have glasses, I'm going to clip it right onto your glasses. If you don't have glasses, I'm going to make you put on a pair of glasses with no power in it and clip that telescope on. I do all the work. I focus it, I align it. All you have to do is look across the room at the eye chart to see if it makes an impact, if it makes it better, if it makes it worse. And as I mentioned earlier, 9 times out of 10, that telescope is going to make things a little bit clearer. But here's the kicker. Who cares if you can read smaller letters on an eye chart? You're not going to go home and read eye charts. What would you use it for? The nice thing about a telescope is, so for example, when you're looking at your TV and you're looking at the on-screen TV guide, a telescope can be helpful to read that. If you're at McDonald's or Burger King and you want to be able to read the menu board, a telescope is helpful for that. It's not going to help you to read your mail. It's not going to help you to read your computer. So go back to that toolbox analogy. What are our goals? What is it you want to see? So we start with a telescope. Then after we take a look at the telescope, then I'm going to do some math calculations based upon your vision. And I'm going to start with a microscope lens. A microscope is a high-powered reading lens to try to make reading easier. The nice thing about a microscope reading lens is your hands are free. If any of you have tried a handheld magnifier, you know how hard it is to hold your paper or your mail in one hand and the magnifier in the other hand and get it all lined up, and there's glare around the edges. Don't get me wrong, handheld magnifiers are great, but they have their limitations. So when we can take that magnification out of your hand and put it into a pair of glasses, now your hands are free. But there is a trade-off, okay? Everything we show you is going to have that double-edged sword. Things you like about it and things you don't like about it. When I put the magnification into a pair of glasses, what you're reading has to be brought closer to your face. You can't set it out here on the kitchen table anymore, okay? That's the trade-off. So literally, I'm going to borrow your paper. We put the microscope reading glass on. I tell the patient, bring it all the way up, touch it to your nose. Can't do anything until it touches your nose, and then slowly pull it away and stop when you can read the tiny letters at the bottom of the eye chart. That's uncomfortable. The success with any of the magnifiers that we show you depends upon 2 things. Number 1 is ability. The telescope, like I said, 9 times out of 10, the telescope is going to allow you to read smaller print on the eye chart. But what would you use it for? Again, if you don't have TV isn't your thing, you're not a student in a classroom where you need to be able to see what the instructor is doing across the room, you may not have a need for a telescope, okay? Same thing with the microscope, bringing it up and holding it close to your eye. What would you use it for? That might not be the most comfortable tool to use for leisure reading, but might be a great tool to use for reading labels, okay? For sorting your mail. That kind of a thing. So everything comes back to what your goal is. What is it that you want to accomplish? And then we try to help you put together those tools in that toolbox that will help you to do that. Okay? Up here are various magnifiers. These are all spectacle magnifiers, microscope magnifiers. Okay? They're all various forms of glasses. And again, the downside to spectacle magnification is the close working distance. A lot of patients, I want to be able to read the hymnal at church. And so I get them reading tiny print and they say, well, then I'm not going to be able to sing if I have to hold the hymnal right up here to my eye. So again, it's finding, so what if we went less magnification and do they have a large print hymnal at church that you could use? It's finding all of those things that will make it easier for you to do the things that you want to do. So after we figure out, 1, does magnification help? 2, how much magnification is it going to take to help you see what you want to see? That's my piece of the puzzle in this whole low vision rehabilitation process. Once I have figured out that information, then I have a conference with the occupational therapist, let her know what I found, and then I transfer the care over to Lauren or Susan, and I say, this is when the fun starts. Because now we're going to look at all the different tools. So spectacle magnification or eyeglass microscope magnification is just one tool. For most patients, when I say the word magnifier, they're thinking a circle with a handle on it. Okay? But that's just one example of a magnifier. So the amount of magnification will be available in a handheld. It'll be available in a handheld with a light. It'll be available in a stand magnifier, kind of like a paperweight. A stand magnifier with a light. It'll be available in electronic or digital formats, like a portable video magnifier about the size of a cell phone. It'll be available in what looks like a computer, a desktop. So there's lots of different ways to get the magnification. The fun starts when I transfer you over to the occupational therapist, because that's where you get a chance to get your hands on it, try it out. See if, maybe holding it that close isn't that bad. So I am now going to turn it over to Lauren because, like I said, that's when the fun starts.
Hello. So, like Dr. Hinson said, my name's Lauren. I'm an occupational therapist at Vision Forward. I've been working there for over 14 years, and Dr. Hinson's been even there longer than me. So together we have a lot of experience. There are 3 occupational therapists at Vision Forward that Dr. Hinson makes referrals to. All 3 of us also have a certified, we're certified in low vision as well, so we are very specialized. So in my first slide, it's already moved. I'm just going to talk a little bit about the role of occupational therapy. Who's worked with an occupational therapist before? Yeah, we're all over the place. We work with every age from newborn babies to senior citizens. We work in several different locations from birth to 3 programs to schools, rehab facilities, hospitals, clinics, skilled nursing facilities. So we're kind of all over the place. Our focus is always on occupation though. And occupation stands for meaningful daily activities. And so at Vision Forward, what we do is we work with the vision that the client has that day. We know that, people have fluctuating vision. Sometimes it's better or worse. We know that vision diseases progress and, sometimes they're going to get worse. But when we work with the client, we're kind of focused on the vision at that particular time. And our goal is to work with loss of ability relating to vision loss. So we really, Dr. Hinson talked a lot about goals. We really need to figure out what people are struggling with and then come up with adaptations or modifications to help people do what they want to do, to increase their quality of life, to be more independent, to be happier people. Okay, so Dr. Hinson in her office, it's very controlled. She was even saying with the telescope, she does all the work. She lines it up. All the person has to do is look through the telescope. She uses eye charts, which are designed to make reading as easy as possible. They're dark writing, white background. I kind of consider the occupational therapists at Vision Forward to be the bridge between the information that Dr. Hinson gathers and also working with the client so that they can apply it in their daily life. We know that how well a person reads or sees something in the distance in Dr. Hinson's office does not necessarily translate to how well they're doing in the real world. So I have here just some pictures of things that people are actually doing. And obviously there's a huge difference in the way these things look than the eye charts look. So Dr. Hinson does an assessment and she establishes goals. The occupational therapist does an evaluation as well. And I would have to say ours is in a lot more detail. We are the ones that are going to be having a relationship with the client for numerous sessions. And so in order for us to work together, we really have to know some background information. So one of the things I like to know is how long the person has noticeable vision loss. And there's a difference between when the person was diagnosed versus when they started struggling. And so somebody who's had vision loss for 10 plus years is going to be different from an emotional standpoint than somebody who recently has vision loss. They're just in different places. And so it's important to know where they're at emotionally with the vision loss. I also need to know health-wise, how are they doing? Do they have diabetes? Are they able to manage their diabetes safely? Do they have any range of motion issues in their shoulders or mobility issues? With being able to walk. Have they had any recent falls? All these things, I kind of just want to know health-wise what they're dealing with. The living situation. So do they live alone in a senior center? Are they getting assistance? Maybe they're younger and they have a family that they have to take care of. Maybe it's a child. We do at Vision Forward work with people of all ages. The majority of our clients are adults, but we do work with all ages and a lot of working adults. We get a lot of referrals from the Department of Vocational Rehab. And so if I say the words or the letters DVR, that's what that stands for. And so we work with people of all ages, and as a result, their needs are different. What support do people have? Some people have support coming out of their ears. They have family members that live with them or nearby, and other people just not so much. And sometimes maybe the person with the vision impairment is the care provider for somebody, or maybe they have pets or something like that. So we just kind of want to know their living situation and also the type of support that they currently have. I like to know what devices they've been trying to use. We ask people to bring their current magnifiers with them. I like to take a look and just kind of see what powers they are, what kind of shape they're in, if people find them helpful. I've found a lot of times that people they have decent devices. They might just not be using them appropriately. Or maybe it's not the right power for what they're using it for. So maybe somebody's trying to read with a magnifier and it doesn't work for reading, but maybe it would work for looking at appliance dials or something like that. And then what we do is we really go into detail with the daily activities, kind of going back to occupations. This is really our focus with occupational therapy. I want to know what people are doing during their days, what maybe they would like to do that they've stopped doing because of vision impairment, and if they're still doing them, but maybe it's a lot more challenging than it used to be. Maybe it's taking a lot more time. Maybe they're able to do it, but it takes 3 tries to accomplish it. One thing that I think it's important to understand is that every daily activity that we do takes a certain amount of energy. And somebody who does not have a vision impairment or, any other disability, we do a lot of these daily activities kind of mindlessly. Like somebody might brush their teeth and think about what they're going to have for dinner that night. But when somebody has a vision impairment, it takes a lot more mental energy to do every single step. And so what happens is that when it comes to being too difficult, people tend to stop. And so, so for example, mail might accumulate because they've stopped reading it, so they set it aside. They might stop making nutritious meals, and now they're eating, much less nutritious fast meals. Leaving the house, this is a big one. If you think about all the energy it takes to go somewhere where you're not, especially where you're not familiar, just for anybody. And then if you take somebody who has a vision impairment and maybe they have a bad back or they use a walker, what happens is they stop doing some of these things. Like they might stop going to church. They might stop going to the dentist even. So we really kind of want to get into activities that they used to do and maybe are no longer doing. Okay, so Dr. Hinson talks about goals. The occupational therapist is going to go into, once again, more detail with goals. The goals have to be client-centered. We always invite family to the sessions. It's always good to have an extra set of ears. But, if the adult son or daughter says, Mom, you used to knit, why don't you have that as a goal? And then the client says, no, I've stopped doing that and I'm fine. I don't care. That's not their goal. That is the adult son or daughter's goal. So in order for the goal to be meaningful, it really has to come from the client because there's some work we have to do in order for them to accomplish these goals. So if there's not motivation, it just might not be a realistic goal. Let's see. Specific. So, like I was saying before, like every activity that we do, there's different steps. So if somebody wants to fry an egg, they have to get the eggs out of the fridge. They have to crack the egg. They have to be able to turn on the burner, find the right pot. So you can kind of break down every activity into different steps. Some steps the client may really have absolutely no problem with, but other steps they might. And so we really need to kind of be specific on what they're struggling with to get the most out of our sessions. And then the last thing is I prioritize the goals with the clients. I want them to tell me what's the most important for them. Because if they come in and reading the newspaper is the number one thing, but they may have mentioned that they have a hard time, getting the toothpaste on the toothbrush, but that it's really not that important to them. And if that's what I'm focusing on, I'm going to lose them. So we really want to know what is the most important to the client. Why did they come? What got them through the doors? And then we want to focus on the most important things first and then kind of go from there. I do want to say any activity, no matter how big or small, can be addressed in low vision services. I think a lot of our clients, they say, I get by, it's fine, it's not that big a deal. But if it takes them 3 tries, to put the microwave on for a minute, it's those little things that add up, and by the end of the day, there's frustration. So the low vision process at Vision Forward, we do have multiple sessions. It's every now and then it's a one and done, but that's not very often. Usually we establish the goals and then we have to meet with people as many times as needed. And so it just varies on the client and their needs. We do clinic visits and we also do home visits. So I personally feel like there's no question that I do the best work with my clients in their natural environment. In the clinic, there's definitely some things that people need to be in the clinic for. We have some devices that are really large and big, but, I want to work with the person where they spend their time. because it's not just the activity, it's also the lighting, the glare, the positioning that they're in. So in the clinic, I can talk and talk and talk, or I can be in the home and just do. You know, so I like to do home visits as often as possible. Goals can be added or changed. So, you know, we have day one where we talk a lot about goals. But, you know, goals can always be adjusted, or sometimes, you know, we'll even start working on a goal and the client really, they just say, it's really just not that important to me. I don't want to do this much work in order to do this activity. So goals, you know, just because they're established on day one, it doesn't mean that they can't be adapted. Sorry, I can't. So, I mean, talk about vision. I can't read my notes. So.
Try a magnifier?
Okay, so once all the goals are met, and that comes from the client, you know, I want the client to feel satisfied. So I ask them, you know, I always say, you know, is there anything more that you feel like you need? Do we have to address anything more? We will discharge at that time, but we are a service for life, you know, and I think that's one of the wonderful things about Vision Forward is we serve clients of all ages throughout their lifetime. So vision does change, goals change, needs change, lifestyle, you know, situations change. You know, when I'm working with somebody at one point, maybe they have a spouse that they're living with and they have a lot of support. And then as time goes on, maybe that spouse is no longer there or available to help. So our clients can always return, and they do. We do get a lot of returning clients that come back when something changes.
I just want to add to that, you know, Luke and Corey are here, you're going to be listening to them. Not only could your vision change, but technology changes. The things that are available to enhance your vision and make your life easier, it changes dramatically. I mean, we've seen patients who are born with vision loss who, you know what, let's just come on back in for a refresher. Let's see what's out there. Let's see if there's a tool that you didn't even know was available that could be life-changing for you. So there's lots of reasons to come back again.
Yes, and we 100%. We get people who have had vision loss for a long time. They just want to see what's new out there because, believe me, there's always new stuff. Okay, so just talking, you know, in Dr. Hinson's office, she's really focused on magnification. But, you know, that bridge, the functional aspect of low vision is that we want people to be efficient. We want them to be able to do a lot of these activities, you know, quickly. So, and you know, like reading and TV viewing, it's definitely easier to use optical devices because people are still, what they're looking at is still, they're at kind of a set distance from what they're looking at. But when your head is moving and your body's moving, or you're walking around or you're holding things, optical devices are just not very convenient. And so we like to use what I call non-optical devices, which are, I'm going to kind of go over them in just a second here, but that's, you know, not using magnification. You know, how can we enhance people's vision without magnification? The first one is lighting. There are two types of light. I break it up in two categories. There is ambient light, which we have in this room. You know, we have overhead light, and then we have task light. Task light is something like on a gooseneck that you can position directly over what you're looking at. It is that concentration of light that makes the biggest difference. I have people all the time when I say, well, what's your lighting situation like at home? And they say, oh, it's good. You know, I've got a lamp right next to my chair where I read. But if it's a light that's kind of similar to that picture, the picture to your right, what they do is they contort their bodies like this. You know, so they need the light, they want the light, but they are not comfortable. And what they're doing is getting secondary injuries in their back and neck and all that. The best type of light usually for people with vision impairment is light that is like, we're talking like 6 inches away from the reading material. So the gooseneck is key because you want it right over. Lighting is good for everything. Honestly, it's good for, obviously it's good for reading. It's good if you want to see the food on your plate better, if you're doing any type of writing. Even to see your I've got a bunch of gadgets I'm going to show, but to see them a little bit better, lighting. And so that's one of the nice things too with being in the person's home is I can help position the light in the best way. Contrast enhancement. So light on dark, dark on light. It's a lot easier for people with vision impairments to see things that have high or good contrast. When the object that you're trying to see blends into the background, it's really hard for people with a vision impairment to identify it. And so I have a few examples on the PowerPoint. I've got the coffee example where if you're drinking coffee and you put it in a black mug, is there even coffee in there? It's harder to see than if it's in a white mug. There's also a light switch, which wouldn't be super easy to see in the dark, but if the light is on and you're trying to find the light switch, having a good contrast is good. And then the toothbrush example. So, we always use the toothpaste and toothbrush example. I was thinking I wasn't going to use it because I feel like it's overused by us, but I had a client on Wednesday of this week. He mentioned it 3 times.
He said it to me too.
Oh, really?
Yes.
So, it's these little things. He was saying that every time he tried to put the toothpaste on the toothbrush, he made a mess. And so, contrast, it can help. I've got some other examples. Got a nice big clock here with really good contrast. White writing on a black background. And nice and big, too. Keyboard. Large print, good contrast. Cutting board. One side's black, one side's white. If you were cutting an onion, it would be really hard to see if it was on the white side. So if you flip it around and now you've got a white onion on the black surface, much easier to see.
And if there's anyone who can't see who's in the back or sitting anywhere else in the room, Lauren will have these later and I'm sure we'll be happy.
Absolutely, absolutely. And I hope that I'm explaining them to you enough so that if you can't see them, you at least... So, I give examples a lot in sessions. And like, let's just take the coffee example. I'll give that as an example. And the person will say, oh, no, I don't drink coffee. What I want you to do is take the idea and apply it to every room in your house. Can anybody think of a situation where contrast would be better? Just think of your bathroom. Is there anything in the bathroom that kind of blends in and you're having a hard time seeing it, but maybe you could put like a black towel under it to make it pop out more. So I just want you to get the idea and apply it as needed. That's really what I'm trying to do. Some of them look like those virtual reality goggles. The one to your right, it's called the Orcam. And that is a device that will talk out loud to you. So you can kind of point to what you want it to see and it will read it out loud to you. It can also identify people if they're within a certain distance and if they've been pre-programmed. There's a lot that I don't know. And so it's really nice that we can make referrals at Vision Forward for the things that for as far as orientation and mobility and a lot of the technology, I'm going to refer. We have a social worker for the emotional needs. The other day I was working with a client and, I've been working at Vision Forward for 14 years and I had somebody ask me how to clean up the mess after their dog pooped pooped, basically. And I had no idea. I was like, that is a really good question. How would you know how to clean that up? And so I had to ask Corey because he has experience with guide dogs. And so, and did you know that they do have diapers for dogs? Like, I did not even know that, but that was one of the solutions. The other, is just kind of feeling where the dog kind of squats down.
The dog's back, not where the dog is going.
Exactly. So the point is that, I learn a lot from my clients just with their needs and their questions. So, are there any questions? Go ahead.
My wife is the one that has vision impairment. She has found that putting the toothpaste in her tube in her mouth first
Yeah. Yep.
is the best way for her to do it.
Exactly.
That wasn't mentioned, so I thought,
Yep. There's all, and that's a perfect example because there's always like more than one way to do something. And so we just kind of help people come up with solutions to make their life easier, and that's perfect. Any other?
One of the slides that Lauren had up there, one of the last ones, was Erica, our social worker.
Yes.
And if I could insist that every one of my patients have at least a session with Erica, I absolutely would. I can't, but I would make it a mandatory thing. You don't know what you don't know, okay? And getting together, just like your example, sir, of the, putting the toothpaste in the mouth. Networking, it's no different than networking if you were a professional and you're just, hey, how do you do this? What did you do in this situation? To hear from somebody else who is living it and how they accomplished their goal is huge. One, it's affirming to you to know that I'm not alone. I'm not the only one, okay? Your family member, your spouse, they love you to death, but they're not experiencing what you're experiencing. And to sit down and talk with somebody who is living it, who this is how I accomplished it, can be very affirming. And the flip side of that coin is you might be a help to somebody else. So I would encourage you to either find a local support group, a low vision support group. We have support groups at Vision Forward. I would strongly encourage you to get involved, even if it's just once a month or once a quarter. Just get out there. Do what you're doing today. Get out there and get as much information as you can for yourself. But the flip side of that coin is you might be the help that somebody else is looking for.